are two blocks that are these are two blocks that are quite dear to my heart, and in our institution, we is a nearly daily basis. As far as lower limb surgery is concerned, the choice of regional anesthesia always is neuraxial blocks. One can locate the subarachnoid or epidural space via a single injection, either via midline or a paramedian approach. Bilateral and multidermatomal coverage is assured with either a spinal or an epidural, and so also is dense sensory block, especially with spinal. Both somatic and visceral analgesia are assured, and there is suppression of the surgical response. And needless to mention, there is no use on systemic opioids. The non-neuraxial peripheral blocks of lower limb is that, unlike the upper limb, the lower limb is innervated by nerves that arise from two distinct plexi, the lumbar plexus and the sacral plexus. But today, we are in the era of enhanced recovery after surgery, which means that the orthopods want their patients to go home early after surgery with minimal pain and a will to comply with physical therapy. Ultrasound guidance has added further precision and safety to our practice of deeper blocks in the lower limbs. And in almost all these patients, there is a reliance on antithromboembolic prophylaxis in the immediate postoperative period. So why do we do lumbar and plexus blocks? One, there is complete unilateral anesthesia and analgesia for the lower limb that is to be operated upon, and there are no hemodynamic perturbations that may follow a neuraxial block, especially in very sick geriatric patients. And despite the fact which calls for a certain degree of expertise, the paradox is that we tend to choose these blocks in fragile geriatric patients with multiple comorbidities who present for emergency surgery for fixation of a fractured hip. And prior to performing this block, we have to ensure that there is no residual blockage from an on-arrival block in the emergency room, which is typically a fascia iliaca block or a femoral block, or in some centers, the PENG block. Now, as you can see from this picture, the anterior capsule of the hip has a huge percentage of nociceptors, whereas the posterior hip capsule is replete with mechanoceptors. The anterior hip capsule is majorly innervated by the femoral nerve, the obturator nerve, and when present, the accessory obturator nerve. Whereas the posterior hip capsule is innervated by branches of the sacral plexus, namely the superior and inferior gluteal nerves and the nerve to quadratus femoris. It is important to note that all these three nerves are high branches of the sacral plexus, which leave the sacral plexus quite proximally. As always, the prerequisites for regional anesthesia would include an informed consent, a working intravenous access, routine ASA monitoring, the availability of the requisite equipment for regional anesthesia, the presence of a last rescue kit in the operating room, maintaining aseptic precautions, anxiolysis for the patient as per need. We document the procedure and also follow up the patient in the immediate postoperative period until resolution of the blocks. We'll first deal with the lumbar plexus. Nerves of the lumbar plexus arise from the ventral rami of L1, L2, L3, and L4. There are a total of 6 nerves of the lumbar plexus. 2 nerves emanating from one root, 2 nerves from 2 roots, and 2 nerves from 3 roots. The 2 nerves that arise from a single root are the iliohypogastric nerve and the ilioinguinal nerve. The 2 nerves that arise from 2 roots are the lateral femoral cutaneous nerve of thigh and the genitofemoral nerve. And the 2 nerves that arise from 3 roots are the femoral nerve, which is the largest nerve of the lumbar plexus, and the obturator nerve. Now, the nerves, after exiting the intervertebral foramen, they course inferiorly and laterally within the belly
सर क्या
of
घेऊन जा
the
सर
psoas major muscle, and they enter the thigh in the anterior compartment. This is a cadaveric dissection of the psoas muscle showing the lumbar plexus nerves coursing within the muscle. And this is another picture in which the psoas muscle has been dissected out to show that the nerves are coursing through this muscle before exiting the muscle. And this is a cut section at the level of L4. Here you can see that after exiting the intervertebral foramen, the lumbar plexus nerves, they enter the psoas major muscle at the junction of the fleshy anterior 2/3 and the posterior third. And as you can see in this picture, in the vicinity of the lumbar plexus are ascending and descending lumbar arteries and veins. And the presence of these vessels in close proximity to the lumbar plexus nerves is a point of concern. As far as technical approaches are concerned, Winnie and colleagues in 1973 introduced into clinical practice the now redundant 3-in-1 block via the anterior approach. They believed that with a single injection, there would be rostral spread of the local anesthetic to block the femoral nerve, the obturator nerve, and the lateral femoral cutaneous nerve of thigh. In the very next year, in 1974, the same set of anesthetists, Winnie and colleagues, came up with the landmark and tactile feedback-based posterior approach to the lumbar plexus. The laws of resistance approach was introduced by Cheyenne and colleagues in 1976, and peripheral nerve stimulation was first used by Parkinson and colleagues in 1989. Kirschmeyer and colleagues in 2001 first performed the lumbar plexus block with ultrasound guidance. And today, the gold standard, where possible, is dual guidance by combining both ultrasound and nerve stimulation. Now, Cheyenne and colleagues, they brought into literature the term the psoas compartment block. Now, these authors, they postulated that in between the psoas muscle and the quadratus lumborum muscle, there lay a psoas compartment wherein the lumbar plexus nerves would lie. And when the needle walked off the transverse process and entered this so-called psoas compartment, there would be a loss of resistance. Today, we know that no such compartment exists. So the term psoas compartment block is not to be used anymore, and we should call this the lumbar plexus block alone. This is on the left, Winnie's approach. Now, this is the iliac crest. This is the posterior superior iliac spine from which a line is drawn superiorly. And this is the L4 vertebra. If a line is drawn laterally from the L4 vertebra, the junction of these two lines is the place where we would put the needle when we do the block with the Winnie's approach. Now, Capdevila, Philip Macaire, and colleagues in 2002 modified the Winnie's approach because they believed that if the needle was introduced here, there were instances where we were missing the transverse process and the needle would be encountering the plexus within the psoas muscle. So the needle entry point became the junction of the medial two-thirds and the lateral third of this line drawn laterally from the L4 vertebra. The depth from the skin to the transverse process could vary depending on the patient's body habitus. But having reached the transverse process and walked off the transverse process, the lumbar plexus is always encountered at a depth not exceeding 2.2 centimeters. Now, these are the landmarks I drew in a volunteer I had with me. This is the posterior superior iliac spine. That's the iliac crest. This is the greater trochanter. This is a line connecting the posterior superior iliac spine to the greater trochanter. This is the ischial tuberosity. And at 6 centimeters distal or inferior on this line is the insertion point for the parasacral block. And this typically corresponds with the commencement of the intergluteal cleft. This is L5, this is L4, this is L3, and that would be the insertion point for the needle when we perform a lumbar plexus block. That is the junction of the medial two-thirds and the lateral third along the line drawn from L4 laterally. Now, in a big patient, palpating the posterior superior iliac spine is not always easy. It calls for a bit of patience, and sometimes initially we would take help from the orthopedic surgeons to be able to palpate the PSIS in huge patients. Believe me when I say this, drawing the surface anatomical landmarks correctly on the patient's skin is a sure shot recipe for success and also reduced needle passes when we are performing a lumbar plexus block. Now, this is the position. The patient lies lateral. Uh, the operator sits posterior to the patient. We have an ultrasound machine which is ready here in case I need to use it. And as you can see, the starting current here is 1.5 milliamperes. I've gone for a higher current in this geriatric asthenic patients because in geriatric patients, we would expect the muscles to be quite sarcopenic. And the stimulation that the electrical stimulation can elicit in terms of a twitch may not be as vigorous as in a younger patient. Now, this is a small video. That's the PSIS. This is L4. This is L5. I marked this insertion site. This is the DG Stimuplex, which we used to use on those days. And this can go all the way up to 5 milliamps. We typically start with 1 milliamp, but in elderly patients, I start with 1.4 or 1.5. And when we get the stimulus, we tend to go down to 0.4. This is the anodal connection, which is connected to the patient. So that is positive to patient. And this is the cathodal connection, which is connected to the block needle. So that is negative to needle. And that is a 100 millimeter needle with an injection port. And that is the needle being placed. And I'm aiming to contact the transverse process. And the endpoint would be a good twitch of the quadriceps femoris muscle, as you see here. And that is the quadriceps contraction. We tone down to 0.4, and once we see that the contraction is still there, we go ahead and do a fractionated injection of the local anesthetic. And as you can see here, the moment the injection is made, the contraction disappears, and that is what we call the positive Raj test. It is quite important to be able to differentiate various muscle twitches when you perform a lumbar plexus block. If the twitch is limited to ipsilateral back muscles, then we are very superficial. The needle is lying within the erector spinae muscle. If there is a twitch of that the needle is too caudal involving the lumbosacral trunk. If there is a flexion of the thigh at the hip, that indicates psoas contraction anterior to the lumbar plexus. So we need to withdraw the needle backwards towards the posterior part of the lumbar plexus. And when we see a good twitch of the quadriceps femoris muscle, that is when we accept the twitch and proceed to deposit the local anesthetic. Now, this is one block with the highest bleeding risk. It is an advanced level block and not for patients who are on anticoagulation. The list of complications is quite frightening. You can have an epidural spread, you can have total spinal anesthesia. Mild hypotension typically follows sympathetic denervation of the fractured hip once the block begins to act. You can have a plexopathy or a neuropathy. Local anesthetic systemic toxicity is an ever-present danger because of the ascending and descending lumbar arteries and veins in the vicinity. So always aspirate and ensure there is no blood in the injection port before we inject the local anesthetic. We can have intraperitoneal injections, retroperitoneal hematomas, and subcapsular renal puncture also has been reported. Now, this was a paper by Jeff Gadsden and Admir Hadzik and colleagues that was published in 2008. They divided 20 patients into two groups. In one group, the injections were made with high pressure against resistance. And in the other group, they were performed with low pressure without any resistance. And as we can see in the high pressure injection group, the incidence of neuraxial block and the incidence of ipsilateral sciatic nerve block was 50%. So we are encouraged never to inject when the person who's doing the injection says that they're meeting a lot of resistance. It's best to reposition the needle, reconfirm the twitch, and then inject. This is the initial paper that was published by Kirschmeyer and colleagues in 2001. They introduced the ultrasound-guided lumbar plexus block into clinical practice. And as you can see here, the picture on the right is the sagittal scan, and the picture on the left is a transverse scan. And there are two views basically. One is a paramedian sagittal scan, the other is a paramedian short axis or transverse scan. Now, when you do a paramedian sagittal transverse process view, you place the low frequency curve transducer to insonate over the transverse process and the space that lie between two contiguous transverse processes. So posteriorly, this would be the erector spinae. This is the acoustic shadow cast by one transverse process. This is the other. This is the other. This sort of representation has been likened to the ultrasound trident by Manoj Karmakar and colleagues. And between two contiguous transverse processes is an acoustic window wherein you would see the psoas major muscle. And at the junction of the anterior third and the posterior two-thirds, this is where you would see the lumbar plexus nerves coursing. And this is the placement of the probe in the paramedian sagittal plane, and the needle would go from caudad to capillad in plane with the ultrasound beam. Now, this is the paramedian transverse oblique scan. You can place the needle either just lateral to the transverse process or in the flank so that we are able to insonate and find the ultrasound shamrock. Paramedian is clear. Transverse is also clear. We also add the word oblique because we are tilting the probe medially towards the midline. Now, this is how the operator would sit. and facing the back of the patient and also the ultrasound machine. Now, when you place the probe just lateral to the transverse process, you have two views. One is the transverse process view, and the other is the articular process view. The advantage with this particular view is that when the needle comes in this manner, one need not have to walk off the transverse process to make contact with the lumbar plexus now, which is here. Now, the ultrasound shamrock was introduced into practice in 2013 by Heinz Borglum, Bernard Morrigal, and colleagues. They published this work in the British Journal of Anesthesia. Now, this is the shamrock flower, which has a stem and three clovers. Now, the shamrock has been likened to the Holy Trinity by Saint Patrick, the patron saint of the Republic of Ireland. And in that country, the shamrock is considered to be a holy flower. Now, in ultrasound terminology, the stem of the shamrock is the transverse process of the corresponding vertebra. One clover is the quadratus lumborum muscle, one clover is the erector spinae muscle, and the third clover is the psoas major muscle, and that is the lumbar plexus nerve emerging there. So when you place the probe in the flank to perform this sort of a block, the needle insertion is here, which is at a certain distance from the probe. And we must make every effort to ensure that this needle corresponds with the ultrasound beam. Again, you can have a transverse process view, or you can also have an articular process view, where then there is no impediment to the passage of the needle as it ventures towards the lumbar plexus. Now, this is a block I performed in a 12-year-old child just a few days ago. This is the transverse process. This is the body of the vertebra. You can see the lumbar plexus, the nerve emerging here. This is the psoas muscle, and this is the quadratus lumborum. You can see the needle. It's coming here in this manner. It's going through the erector spinae muscle. And I'll just play this video for you. And as the local anesthetic is injected, you can see the spread going all around this particular area. And the lumbar plexus now becomes very clearly seen. And the needle is also removed under vision. And this is the area where you would find the kidney. Now, this is another patient in whom this is the transverse process. This is the body of the vertebra. You can see the lumbar plexus nerve here surrounded on all sides by the local anesthetic. So that is how you would perform an ultrasound guided lumbar plexus block. But again, we would tend to use dual guidance in all instances, except I did not use peripheral nerve stimulation in that child because he was under GA with muscle relaxation. We'll now talk about the sacral plexus. The sacral plexus arises from the ventral rami of S1, S2, S3, and S4. There is also contribution from the lumbosacral trunk, which majorly arises from L5. The largest branch of the sacral plexus undoubtedly is the sciatic nerve. The other notable branches are the superior and inferior gluteal nerves, the posterior femoral cutaneous nerve of thigh, which gives sensory innervation to the back of the thigh, and the pudendal nerve. Now, this is the sacral plexus arising from S1 to S4, and this is the lumbosacral trunk. Now, the sacral plexus becomes posterior by exiting the greater sciatic foramen. This is the sacrospinous ligament of, and as it exits posteriorly, it emerges from, and as it traverses distally, it overlies the superior gemellus the obturator internus, the inferior gemellus, the quadratus femoris muscles before making its way into the back of the thigh. Now, the sciatic nerve and the sacral plexus, they lie under the huge bulk of the gluteal muscles. And here in this picture, I've highlighted the right sciatic nerve in green. That would be the superior gluteal nerve. That would be the inferior gluteal nerve. That would be the posterior femcutaneous nerve of thigh. And that would be the pudendal nerve. Though anatomically, as you can see in this picture, the sciatic nerve bifurcates just proximal to the popliteal fossa here. Histologically, right from its origin, the sciatic nerve is two distinct nerves, which is the larger tibial nerve and the smaller peroneal nerve. And there is a distinct septum in between the two nerves, which is histologically also called the Crompton-Cruveilhier septum. Now, in the picture on the left, you see the anatomical landmarks highlighted in green, the posterior superior iliac spine, the iliac crest, the ischial tuberosity, and the greater trochanter. And that is where you would perform the parasacral block. In 1993, N.Y. Mansoor, an anesthetist working in Medway Hospital, Gillingham in Kent, in the United Kingdom, in a correspondence to the Regional Anesthesia and Pain Medicine Journal, spoke about a new approach to the sacral plexus, which was proximal to and distinct from the Labarthe approach. And that is the insertion point for the needle. That is the PSIS, as I told you earlier. This is the ischial tuberosity, and this insertion point lies exactly 6 centimeters along this line, and it typically corresponds with the onset of the intergluteal cleft. Now, the parasacral block of Mansour is the most proximal approach targeting the plexus. There is spillover of the local anesthetic to involve the pelvic splanchnic nerves, the terminal part of sympathetic trunk, and the inferior hypogastric plexus. And as you can see from the picture on the right, it can also often affect the obturator nerve, which passes quite close by. In that sense, this is a very profound block and not to be taken lightly. And as per Mansour, the twitch of hamstring muscles was considered to be adequate. Now, when you stimulate the sacral plexus, you may either stimulate the tibial component or the peroneal component. When you stimulate the tibial component, the responses you can expect are inversion and plantar flexion. And when you stimulate the peroneal component, this twitches you can expect are eversion or dorsiflexion. Now, this is the entry point for the Labarthe or Vinny's approach. This would be the entry point for the parasacral block of Mansour. But I'm just putting up this video to show you all the responses: plantar flexion, dorsiflexion, eversion, and inversion. Just by moving the needle a bit, medially and laterally, you can stimulate either the peroneal component or the tibial component. But I would advise you not to do this. The best would be to go for the plantar flexion. Now, when you do a parasacral block, which component to stimulate? And without any doubt, when we stimulate the tibial nerve, the chances of success are much higher. If you see here, when you stimulate the tibial nerve, as per this study, the chances of success are 80%, whereas it's only around 17% in group 2, wherein the peroneal nerve is stimulated. Now, this was an 84-year-old lady in whom we did a parasacral block a few hours ago this afternoon. And that is the plantar flexion that you see in this patient. In 2011, Benston, Hans Borglum, Morrigal, and colleagues introduced into clinical practice the parasacral plexus block by a technique called the parasacral parallel shift. Now, the low frequency curve transducer is placed on the medial half of the line connecting the PSIS to the greater trochanter. And once you place the probe here, you see a continuous uninterrupted line of bone, which is the ilium, and overlying the ilium would be the gluteal muscles. And when you do a parallel shift towards the sacrum, you will see a break in this bone. And this would be the sacrum here. This would be the posterior border of the ischium. And emerging from under the hypoechoic piriformis muscle would lie the sacral plexus. So this is another representation of the same. This is prior to the parallel shift. You see a continuous uninterrupted line of bone. And when you do a parallel shift towards the sacrum, you see the break in the bone and the emerging sacral plexus. So this is pre-parallel shift, and this is post-parallel shift where you see this particular plexus. Now, this is a video just to show you the same. This is the ilium, and you see the break in the bone. This is the sacrum. This is the posterior border of ischium, and that would be the plexus here, and that would be the piriformis muscle. Now, this is a video that I borrowed from Vicente Rock in Spain. This just gives an illustration of how the parasacral block can be performed with ultrasound guidance. So in conclusion, the take-home message. Both these blocks, the lumbar plexus and the sacral plexus blocks, are advanced level blocks. There is a potential for complications with these blocks. These are deeper blocks. In some instances, in big patients, we often encounter the sacral plexus at a depth between 8 and 10 centimeters. It is very important to understand and mark the surface anatomy on the patient before we proceed to do the block, and we must have a working knowledge of block-related anatomy. Where possible, it is best to combine ultrasound with nerve stimulation. But that said, many a time I rely mostly on nerve stimulation. I use ultrasound as a secondary confirmation technique just to see the spread of local anesthetic. And in some instances where I'm not able to locate the plexus with nerve stimulation alone, I tend to combine ultrasound and nerve stimulation. As I said in a slide earlier from Jeff Gadsden's study, please do not inject against resistance, and always keep in mind that these blocks have a huge potential for complications. With that, I end this lecture. Thank you very much for your attention, and I'm open to taking any questions or suggestions from the audience. Thank you.
Thank you, sir. It was a wonderful presentation, and I hope all fellows have got some important information and some important tips. Sir, I wanted to ask you a question. You told that monitoring the injection pressure or keeping the injection pressure low is important to prevent epidural spread. Any other technique by which we can avoid epidural spread?
One is definitely not to inject against resistance, and the second would be not to inject very rapidly. I typically tend to make my injections over a minimum of 3 to 5 minutes. And I typically give around 20 to 22 ml for lumbar plexus block. So slow injection also prevents retrograde spread of local anesthetic to so that the drug does not enter the intervertebral foramen.
Okay, sir. Thank you. And another issue with lumbar plexus is the injection intravascularly, as lumbar vessels are lying surrounding the plexus. So, how to prevent intravascular injection in these patients, sir?
If you, those who were there in GARC recently, Sandeep actually applied the color prior to performing the block. And the color actually, if you use the power Doppler, you will be able to pick up minor pulsations. And it would be best if the needle can avoid those vessels when venturing towards the plexus. That is point one. And point two, I cannot stress the importance of intermittent aspiration. Lot of times we see that when you aspirate, blood tends to come back into the injection lumen. And that is when we are in a conundrum because by then some local anesthetic has already gone and you will not get a twitch if you try to, you know, reposition your needle. So the best bet in these cases would be to reposition the needle with ultrasound guidance and then proceed to do the block. I just read a question from someone. What is the dose for a pediatric patient? See, in an adult, I would typically give 20 mils for lumbar plexus and 20 mils for sacral plexus, which is typically zero point 0.4 mils per kg for each block. So I would stick to the same dosage guideline even in a child. But at the same time, I would keep the concentration of the drug low so that I don't exceed the safe limit. So I would, in fact, that patient in whom the 12-year-old boy, we did the lumbar plexus block. We just put in about 6 mils of local anesthetic. Yeah, 6 mils.
Thank you, sir. One more question from my side, sir. Once we hit the transverse process, we redirect the needle to walk up the transverse process and to look for the lumbar plexus. So, any difference between directing the needle caudally or cranially, sir?
I would prefer to direct the needle cranially because when you direct caudally, there is always a possibility that you will be eliciting or stimulating the lumbosacral trunk. And in a few instances, we do see that there is a quadriceps contraction as well as a hamstring switch. That is quite confusing. So, where possible, I would always advise walking off cranially rather than caudally.
Thank you, sir. Any questions from fellows or mentors who have joined?
So there is one question from a student, just 1 second, in chat box.
Do we follow any cutoff INR value before giving lumbosacral plexus block in high-risk patients? As I said, if the patient has been on antiplatelets, if it's aspirin, we really not bothered. But if the patient has been on clopidogrel or even ticagrelor, we have to wait for 5 days. And if it is prasugrel, we have to wait for 7 days because the affinity for platelets with prasugrel crosses 90%. INR is an overstated test. INR is typically meant for patients who are on anticoagulants. And INR need not be actually assessed in all surgical patients. INR may vary in septic patients or patients who are on anticoagulants or patients who've got severe liver dysfunction. So If I have to give a cutoff mark for INR, I would say 1.5.
Sir, there is another question, sir. This is from Afrin Shamsuddin. Sir, can navigating needle without connecting to the syringe help identify blood vessels or intrathecal injection? So we keep the needle end open to the air or extension tubing end open to the air. Can it help identifying a dural puncture or blood vessel puncture?
Blood vessel puncture, I'm not too sure, because if you're in small venules, even when you aspirate, a lot of times the aspiration can be negative. Um, to see the spread of CSF coming, maybe yes. But then, I mean, thankfully, in all the blocks that I've performed, I have not had a spinal so far. Epidural, yes. We've had a few epidurals, but no spinal to date.
Okay, sir. There is another question from Dr. Cherukuri Kaushik. Question is, while doing PNS guided approach, if giving a lumbar plexus first has any implication on sacral plexus being pushed away or missed?
Highly unlikely, because the sacral plexus is cocooned in a separate space altogether. So that's highly unlikely. You can have involvement of the lumbosacral trunk, yes. And Jeff Gadsden's study did show that when you inject rapidly against high resistance, ipsilateral sciatic nerve block is also quite high. So there could be an inferior spread of drug to involve the sacral plexus, but not something you encounter very often in practice.
Yes,
I
I have
also read a question which said, I mean, for how long do you expect these blocks to work in the postoperative period? 16 to 18 hours, that's for sure. I typically combine 0.25 and 0.5% bupivacaine, making it a total of 0.375% in terms of concentration. I inject 20 plus 20, that is 40 mils. And I have noticed that my blocks typically last around 16 to 18 hours.
There is a question from Dr. Vipin, concentration or volume, which is more important, and minimum how much required? Minimum you answer, but which is more important, volume or concentration of
I
the
would,
drug?
I would say both, because I perform lumbosacral plexus blocks for surgical anesthesia. And when I do my lumbosacral plexus blocks, other than a wee bit of sedation, we don't do anything else. So for me, both the concentration and volume are equally important.
Mm.
But if I were doing it only for postoperative analgesia, I would stick to 0.2% ropivacaine or 0.25% bupivacaine.
Regarding spread towards sacral plexus, sir, I have observed once. I think I give little larger volume, 25 to 30 ml for lumbar plexus, and drug spreaded to the sacral plexus. And then I was not able to elicit the response for sacral plexus. This is regarding previous question, sir.
I have, in fact, Dr. Prakash is right here. There have been a few instances where I failed to elicit a twitch with the parasacral block of Mansour. In such instances, I have gone ahead and done a Labatz. And I do get a twitch when I do a Labatz. So I don't know if we are looking at some drug reaching the sacral plexus.
Sir, any additives you are using or without
Absolutely
additives?
not.
Yeah.
I personally do not believe in additives. And for such deep blocks where we are targeting an entire plexus, I would prefer not to use an additive because the block as such lasts 16 hours. I mean, what more do you need?
Yeah, that's true,
And
sir.
you can always put a catheter and prolong the block.
Sir, are you using catheters?
I did. I used to use catheters earlier, but then today the focus, even in patients with hip fractures, is on standing them up and walking not later than the next morning. So if you put a catheter, that defeats the purpose of early mobilization. So I don't do that.
Okay, sir. Thank you. There is a question from Dr. Gauri Shankar, sir, regarding time of onset. How long it will take to achieve surgical anesthesia after giving lumbosacral plexus block?
What I typically do is about 5 minutes after I do the block, I take great pleasure in moving the patient's limb. And the patient actually says, I don't feel any pain. So sensory block sets in pretty fast. But to achieve surgical anesthesia, I would expect 30 minutes. And that is the time it takes to position the patient, to clean the patient, to drape the patient. And by the time the surgeon actually gives the incision, it's not less than 25 to 30 minutes after the block.
Sir, since it is a deep block, are you using any sedation before giving this block, or local infiltration is enough to
I
provide
tend not to give any sedation because typically what happens, you would have seen, Hetal, you do this block yourself. After a lumbar plexus block is performed, the patient immediately goes to sleep. There is a bit of bradycardia, there's a bit of hypotension. This is because of sympathetic denervation, which takes away all the pain, and the patient has no more anxiety. And if you sedate such a patient, you probably will miss some warning signs.
Yeah, true, sir. There is a question from Dr. Veena. The epidural complication, how it was identified and how it was managed, sir?
Well, you will immediately be able to tell because we test the contralateral limb for loss of sensation and motor power. And once we see that there's loss of sensation and loss of motor power, we also gauge the height of block. And since we have given a large volume, we are a little worried that there should not be a rostral spread of local anesthetic. We've had a few instances wherein we've had an epidural, but fortunately, no major hemodynamic perturbations. We were able to manage with a bit of fluid and a bit of boluses of vasoconstrictors.
There is one more question from Dr. Neeta D'Souza. Sir, dependent leg discomfort, any suggestion for managing if the surgery prolongs and surgery is only under lumbosacral plexus? And sometimes when patient is on a fracture table,
Yes,
how do you manage?
valid question.
Yeah.
So in such cases, if the surgery, if it's a hemiarthroplasty, they finish in 45 minutes to 1 hour. So I don't worry about the contralateral limb, which is not blocked. But if the surgery tends to prolong for some time, or if the patient is on a fracture table and the non-blocked limb is uncomfortable for them, I typically start them on dexmedetomidine infusion. So they are not aware of that sensation. It's a very good sedative, and patients are quite comfortable.
One more question. What additional supplemental block are needed in your practice for hip surgeries? This is from Dr. Anju.
Well, the subcostal nerve sometimes gives a contribution to the hip capsule. And when you do a lumbar plexus block, unless there is the involvement of T12, which is seen in some patients, you will not have a block of T12. The subcostal nerve is spared. There are papers which say that you can block the subcostal nerve by doing ilioinguinal and iliogastric blocks. And I did read one paper. It was an isolated case report wherein after a partial lumbosacral plexus block, the author went ahead and did a lumbar ESP. And I don't know how they managed all the volume of local anesthetic in that patient, but they claim that after the ESP was done, it worked well.
Okay, sir.
Any need to block cluneal nerves? I would say not.
There is another question from Dr. Kavya Srikant regarding complication. With your experience, sir, which is the most complication you have observed with lumbar plexus block, sir?
Touch wood, to date, I have not had a patient having last with lumbar plexus. I've had a few patients with following a lumbar plexus block who had an epidural. I think one patient we had to intubate because there was a rostral spread of the local anesthetic and the patient was not breathing adequately. But other than that, really, I mean, most blocks go off well. And I think it's just a function of the experience you have and the protocols you evolve over time.
Yes, that's true. Any other questions from fellows or faculties?
So thank you very much, Heather. I think we'll end this session here. Once again, thank you so much for
There is one last
opportunity.
question from Dr. Deepika, sir. For AK, what is your choice of block, sir?
AKA. I would not do a lumbar plexus or a sacral plexus block in a patient with AKA. And typically, AKA would be in patients with vascular compromise. And these patients are normally on some sort of anticoagulation. And we probably don't have the required window. So I would both of which are fairly superficial and can be managed with proper ultrasound guidance.
Thank you, sir. So I think
Thank
all
you.
the queries
Thank
are.
you so much, Hetal. Very good night to all of you. Enjoy your weekend. Thank you for the opportunity, Hetal.